Yeah, I wanted to precisely show the word kyphosis as a true representation of what it is. So these are my disclosures. So very important topic, PJK. It's probably a very common cause for return to the operating room, and a common cause for poor outcomes, and it has impacts on patient satisfaction and unfortunately cost effectiveness of our surgery. So it's a big problem and has significant implications. So just to briefly go over PJK versus PJF. So PJK can often be asymptomatic, and that's when there's a radiographic measure of greater than 5 degrees of progression of the segmental kyphosis above effusion, whereas failure is a 10-degree increase in kyphosis between the upper instrumented vertebra and 2+. So there's usually an associated fracture of the vertebral body or osteoligamentous disruption, pull out of the top hardware. So just a distinction between kyphosis versus failure. You can see it's a pretty broad range of reported incidents, and as little as 5% to as much as 60%. I've even seen some studies that show 80%. So clearly, it's a common issue that we're all going to face. So how do we decide when to do revision surgery for this entity of proximal junctional failure? It's much more common to need to do surgery in proximal junctional failure than proximal junctional kyphosis. Proximal junctional kyphosis sometimes can be asymptomatic, and if it's mild in form, these patients are conservatively managed. But proximal junctional failure is a bigger problem, and in this series by Bob Hart, who's on faculty here at Swedish, about 50% needed revision surgery within the first 6 months, and he created this clinical correlation severity scale that is essentially a mechanism to see how severe the proximal junctional kyphosis is, and higher scores on this scale that he created demonstrated a higher likelihood to need surgery to treat the PJK. So you can use this to help decide whether or not surgery is indicated, but ultimately it's a patient-to-patient determination as far as whether or not surgery should be done. But higher scores on this scale were associated with greater impacts on clinical outcome. So going to go over a couple cases of where PJK was present and how PJK was treated, and how different measures that were used to try to create a satisfactory outcome. This is a referral from one of our local community hospitals. This patient had an L2 to S1 decompression infusion, and as you can see, this was a PJF, significant pullout of the top screws. You can see some significant lucencies around the top hardware. The patient has osteoporosis, and this is a situation where careful preoperative evaluation of the patient's pelvic incidence and lumbar lordosis is important. This is a patient who required a removal of the posterior elements right around that L4 vertebral body. You could see that there was some bone within the canal at that level. This was a 3-column osteotomy, but it was kind of like a fake 3-column osteotomy because all you really needed to do was take out the pedicles of L4, and I placed an inner body at that L4-5 interspace, and it gave me some manipulation to improve the lordosis. This is a surgery where we use cement augmentation. Cement augmentation, in light of her history of osteoporosis, was helpful to provide additional pull-out strength, and you can appreciate the larger diameter screws that were necessary to improve the fixation. And you can see how there was about a 22-degree improvement of the lordosis. And this patient actually did very well. She had a durable response, did not develop any PJK above her fusion, and these films were actually 6 years out, and she unfortunately has passed away. She developed a metastatic renal cell carcinoma and unfortunately passed. But she was followed for 6 years and never developed PJK after this surgery. So now we'll go to case 2.
Charlie, did you know that she had renal carcinoma before?
No, she ended up getting it.
It's the hardest thing for me. Sometimes I feel like the disease that I treat lives in vacuum from possible terminal ailments, and you do this wonderful construct. They're doing well for years, and you'd be surprised how that impacts you when you hear that they have another terminal ailment.
Right. Yeah, I agree with you. Yeah, these patients are susceptible to various problems that totally unrelated to the condition that you just treated. So this is a 58-year-old male with a history of chronic steroid use and hence poor bone quality. Has a history of myasthenia gravis, previous fusion from L3 to S1 that required a L2-3 fusion for the treatment of adjacent segment disease, and this is how I received him. This patient clearly has a lack of lumbar lordosis and had a solid arthrodesis that was uninstrumented at the bottom. And I thought this was the perfect. He had a fixed sagittal plane deformity, so a perfect candidate for a PSO. In this case, this was probably, I guess, a couple years after my fellowship, and we got a good lordotic correction. Happy with myself, at the time, and so initially did great. The patient was very happy, but you can see he developed PJK, and I didn't use any augmentation at the time, and perhaps I thought that was the problem. Did another PSO, extended him up further. Then he developed PJK at that level, and so in retrospect, if I was more careful about the amount of correction that was done at L4, this patient had an overcorrection. So his pelvic incidence and lumbar lordosis mismatch was 29 degrees. However, he ended up having a 42 degree correction. So it was 13 degree correction over what he needed. And that has resulted in this constellation of PJKs. So you fix the PJK and it just keeps on developing. So again, complication avoidance, PJK avoidance, do it right from the beginning, and don't overcorrect. So what are potential factors that could influence PJK? Smoking history, age, the presence of neuromuscular disorders such as Parkinson's disease. These are the quality of the bone. How rigid is your hardware? Are you using quad rods? We advocate for quad rods when we do our 3-column osteotomies, but that also increases the stiffness of the construct, and that can have a bearing on the stress at the adjacent segments. So those are all things to consider. So time for development of PJK. A lot of PJK occurs it's bimodal in its distribution. It can occur early or it can occur later. So that's one thing to keep in mind. A lot of PJK you see early on in the early postoperative period, but you can also see it later, and that's why it's important to keep following your patients. If a year follow-up they're doing well, that shouldn't be the end. These patients need to be seen annually because I tell all my patients who are deformity patients that once you get a deformity surgery, that's your patient for life. You end up being like a primary care doctor for these patients because you're the primary care doctor of their spine. So I tell them, I'm not your primary care doctor, I'm your primary spine doctor. So tips for avoiding PJK is careful preoperative planning. We talked yesterday during the complication avoidance talk for scoliosis. As you are going to be operating on older patients, you don't necessarily need to get the perfect correction. You can, for older patients, the target for the SVA should be about 8 centimeters instead of the standard 4. You got to calculate these parameters and make the appropriate calculations. As time develops, we're getting more and more precise with regard to how we can determine what is the correction that's needed, and we even have now equations that can determine how much correction is needed based on the patient age. Other potential tools that we have is cement augmentation. Cement augmentation hasn't been proven, but I've anecdotally felt that it has been helpful in my practice. A recent article was a propensity-matched series of patients using Merceline tape as a tether to help support the proximal segment. And there's a growing body of evidence to suggest that these tethers may help reduce the incidence of PJK. I think Bob Hart here also studies this, and there's a growing body of literature that seems to be supporting this. This is another recent article just published not too long ago that looks at the evolution of PJK and PJF over a 10-year period, and they divided it into 2 cohorts of the first 5 years versus the second 5 years. And in the second 5 years, there were more utilizations of PJK prevention techniques, including tethering and including vertebral augmentation. Unfortunately, there was no significant difference in the rate of PJK and PJF in the first 5 years versus the second 5 years, which is a sign that we still haven't identified the perfect solution. However, if you don't look at the statistical significance and you just look at the incidence, you can see that the overall raw numbers of PJK have improved, and so we are moving in the right direction, but it's not statistically significant as of yet. Just another quick case: a patient who developed PJK. And required an extension of his fusion, this one I use cerebral augmentation. Did a small PSO at the PJK level, and he's got 8 years follow-up and has been fine ever since. So that's all I have. Most importantly is to remember the pelvic incidence is the foundation for the lumbar spine, and I think that's the key to PJK is to avoid overcorrection. But the key also is patient selection and just realization that it's a common thing and it's important to talk about with your patients prior to surgery. So a quick demonstration that Baltimore is the greatest city in America. That's proof. And this is another reminder that the Spine Summit is March 16th through 19th at the Fontainebleau Resort.
And I highly endorse one of my favorite meetings ahead of CSRS is the Spine Summit. You and your team have created a masterful diversity of opinions and exchange of information. So I really applaud you for your work there. Thank you for this great lecture. I have two quick questions. So in absence of a clear answer for avoidance of PJK/PJF, there's this current trend to undercorrect spines. Now I see, together with MIS surgery, a lot of what in orthopedic terms is called OIF, open internal fixation, in contradistinction to open reduction internal fixation. So, and the excuses then when I call the surgeons who've done this is, oh, we didn't want to overcorrect her. So I see the usual US American excessive pendulum swinging the other way right now, where there's stuff stuffed into patients that's in there and everything's reasonably accurate, except for the patient is pitched forward because they were intentionally or not undercorrected. So do we dial this in like what some proponents of computer formulaic medicine do, or do we still use good Gestalt and try to actually do a deformity reduction that makes sense for the patient? How much is mathematically predictable, in other words, and how much is our Gestalt of this is a good thing for this patient?
Yeah, I think it's a tough balance. I think some of PJK may have to do with the focality of the correction. If you do a large correction in a focal part of the spine, that there's a reflexive reaction that the body has to the areas above, and so I think there's a move towards correcting the spine where most of the lumbar lordosis is naturally present. So if you have a patient with a flat back deformity, you want to try to get their lordosis as close to the bottom as possible, because most of the lumbar lordosis is in the bottom of the lumbar region. So I think that when you do a big correction right at L1, yesterday I showed a case where we did the PSO at L1, and she had a perfect realignment, but she had she was overcorrected and started falling backwards. She didn't develop PJK, so she had issues. So perhaps if the lumbar correction was done at the bottom, she may have had. It's hard to say exactly whether or not that would have changed her outcome, but I agree. It's a Gestalt, like you're saying. I do think though that some of the errors that are very clear are where you do the pelvic incidence to lumbar lordosis mismatch, and you give more lumbar lordosis than they need. You do the +10 rather than the -10, and that's where people really fail. And that's how this person failed. I think the one that I showed earlier, he had 6 degrees more of lordosis than he even needed. If you wanted to perfectly equate pelvic incidence to lumbar lordosis, it was more than he needed. So I guess it's a long-winded answer to say that you have to use your best judgment.
My second question is, I think all are way too focused on doing the surgery as a corrective procedure. Talk to us about prehabbing patients, that they kind of get in the mindset to get out of this forward-hanging, depressed involution position into an expanded, a new personality almost. And then the post-tab things, like my worst nightmare is the walker, or when I, just before rounded, my patients were sitting in there after 8 hours deformity surgery and laying in bed like this. Hi, Dr. Chapman, how are you? And, and then they get pulled out of bed by the nurses on their arms. So prehab, post-tab, what can we do better?
So definitely physical therapy prior to surgery is often even a prerequisite for insurance companies to even allow authorization of surgery. So not only is it a prerequisite for authorization, it's been shown to help with a postoperative recovery. Having strong core muscles and strong extensor muscles are I think very, very helpful, and we advocate for that prior to surgery. They have rolling walkers now that are sort of standing rolling walkers, the tall ones with the handles that go like this, that I try to tell my patients to get because I feel those are useful in preventing that sort of forward pitch that can stress the construct. I think the unfortunate tendency for a lot of surgeons is to not follow their patients after surgery closely enough, and sometimes it gets pushed off to our physician extenders. And I think that it's very important to keep a close eye on what they're doing and how they're doing it, because it has an impact on their outcomes.
Yeah, that latter point I really want to second. My deformity patients, once I've done them, they're part of my family, and I follow them in 2 to 3 year intervals or something like that, and getting old enough that they're not worrying about me retiring. I want to pivot to Dr. Skaggs here. So specifically, decompensation above deformity surgery is a big issue with ADS, but let me focus on one subpopulation, Sherman's kyphoses. So what have you learned about decompensation, junctional failures in Sherman's patients specifically? If you want to expand it to AIS surgery, please feel free to do so.
Yeah, Sherman's, the classic teaching is only correct 50%, because if you correct too much, you're going to get proximal junctional kyphosis. I think that's a reasonable rule of thumb. Another thing that is hard to quantify that I found very, very helpful in adolescent deformity, I learned this from Vern Tolo, is if you put a little bit of extra kyphosis to the top of a long construct, the body reacts by wanting to push backwards. If you make the top too straight, the body reacts by pushing forwards. The head always wants to center over the pelvis if it can.
That's a great nugget right there. So any other thoughts in response to what Dave said? I mean, this is actually amazing where pediatrics and adult kind of comes together.
Yeah, I mean, I think that's very insightful and definitely can play a role in it's especially when you're marching up the spine and addressing kyphosis, higher up, it definitely can play a role.
You know, what's interesting is adolescent idiopathic scoliosis, characteristically you have hypokyphosis. So you could have a perfectly straight thoracic spine, and then you end up having a perfectly straight cervical spine. When you put the kyphosis back into the thoracic spine, it's fascinating watching the lordosis go back into the cervical spine, which probably leads to long-term better cervical health.
Mm-hmm.
But little things matter. Everything matters, in fact. So I like the tall walker. I hate canes. I like trekking poles. I like active exercises to try to dynamically mobilize the posterior chain muscles, which start, as coaches said, from the occiput and go down to our gastrocs. So these are the posterior chain muscles, and we need to educate our patients to reactivate them. So I'm glad to see you do the same things. Tall walkers is my prescription pad, as is trekking poles, and get rid of canes, get rid of regular walkers. As I went down, every single walker in a hospital still was a regular walker. All right, super stuff. Thank you, Charlie.
Thank you.